Hello, everybody. My name is Siva Nandasiva. I'm the Chief Analyst at the King's Fund, and it is my pleasure to welcome you to today's online event. Today, we're going to be talking about the topic of trust and transparency in healthcare data. How can we enable the public to feel more comfortable sharing their data to improve health and well-being of the population? For such a weighty and important topic, we need a great panel, and we've assembled one, I'm happy to say, who will bring a diversity of experiences and perspectives to this issue. Before we get to the panel and get them introduce themselves, I did want to say just a few words about the logistics of how we thought the event might run, because we are recording this session about a week ahead of the live broadcast. So to begin with, I'll do a very, very short piece of scene setting to introduce the topic, and then we'll go to the panel, have them introduce themselves. After that, we're hoping to have about 25 to 30 minutes of facilitated discussion on 3 or 4 of the topics we've been discussing as a panel before the event. And then for about 15 minutes or so, we'll be answering questions. Because even though we pre-recorded this event, we did ask for some questions from you as part of the registration process, and we've selected a few of those to have some interaction and engagement with you. If you want to interact with us over Twitter, then you can interact with the event and the panelists using the hashtag KFOnline. And we'll also make sure to put some resources that are relevant to the topic we've been discussing and also to the panelists at the bottom of the screen, so you can follow that as well. So I hope all of that together gives you quite a rounded experience and a sense that you can engage with us, even if a lot of this material is pre-recorded. So I said we were here to talk about trust and transparency. Well, I can't think of a better time to have this debate. If you think about the timeline of trust and transparency in healthcare data, it does seem to wax and wane. There are periods of incredibly low trust where it's a challenging topic and periods of high trust. And I would say that the zeitgeist is somewhere of a mix between the two. If I think about what the NHS and the wider health and care system is trying to do, so much of that is predicated on the sharing of data so you can understand the health and care needs of a population and plan services accordingly in the long term. At the same time, the public understandably has legitimate questions about how their data will be used. Who will be able to see it? For what purpose am I sharing this data? And what safeguards are in place to make sure the data is used appropriately? And these are legitimate and reasonable questions that we need to answer. That's enough for me. I said it would be quite short scene setting. Let's get to our panel to do some introductions. And I'd like to thank Roche for their support of this event and in making this discussion happen. So why don't we introduce ourselves and say a little bit about ourselves and our roles? So Debbie, over to you.
Thanks, Stuart. I'm Debbie Keatley. I'm a member of a patient movement called Use My Data. I'm personally a cancer survivor and have experiences of caring for someone with cancer as well. And with another hat on, I'm also involved in HDR UK and their public advisory board. And I'm involved as a public representative with a couple of research committees at Cancer Research UK and also with NIHR.
Great. Thank you, Debbie. Over to you, Caroline.
Hi, I'm Caroline Cake. I'm Chief Executive of Health Data Research UK, or HDR UK, and we are the National Institute for Health Data Science in the UK, working across all 4 nations, working on how health data can be used to enable discoveries that improve all of our lives. So be that around how data is used in clinical trials to enable better discoveries, for example, during the pandemic, examples of the recovery trial, or how data is being used to understand causes of disease, or how it's used to improve clinical care, or how it's used on population health. So a whole range of how health data is being really used to make our lives better. We work in really close partnership with members of the public and patients, and as Debbie's mentioned, so our fantastic public advisors. And during the pandemic, have had, I think it's nearly 16,000 people involved and engaged in different aspects of how data is being used for research purposes. And so a really key part of how we see the role of Health Data Research UK, but also the role of patients and public in really making great use out of health data.
Great, thank you, Caroline. Jennifer.
Hi, my name is Jennifer Prunier, and thank you for having me today with you all. As mentioned, I sit serve with Roche as the data policy strategy leader for the purposes of delivering personalized healthcare. So focused on how do we partner with health systems to progress data policy that can help us move towards delivery of actual personalized healthcare. My background, I've spent most of my career working in large-scale public healthcare systems in Canada, implementing electronic medical records and developing and implementing both operational and legislative health policy. So looking forward to the discussion with the colleagues on the panel today.
Great, thank you. And Alistair.
Hello, and thank you. So I'm a NHS clinician. I'm an ophthalmologist, so an eye specialist working in a big hospital in Birmingham, UK. And so I'm here partly as a clinician and as a data user, as it were, on the front line, because of course data is exactly what informs my ability to deliver the right care to the right person at the right time. But I'm also here as a researcher. So I've spent a lot of the last decade in health data research. So trying to use the insights that we get, not just from a single patient, but from understanding what's happening across a whole group of patients, perhaps with the same condition or with exposed to the same risk factor. And then I suppose I have a third hat relevant for today, which is I'm also spending a lot of time trying to make that data more widely available for research that brings benefit back to patients, but to do that in a way that's safe. And so that's really relevant to this whole theme of trust and transparency. And just an important declaration with that third hat, one of the ways we're doing that is with a Health Data Research UK initiative called Insight. This is a hub for health data related to eye health. And that has a number of partners from the NHS, from the universities, from a charity which is dedicated to sight loss, and two industry partners that help support the structure and building of that resource. One is the tech company Google, I think well known to everybody, and another actually is Roche, the pharmaceutical company. So those are my three hats: a clinician, researcher, and as somebody who's committed to try and help that data become available in a safe and secure way for patient benefit. Great,
thank you, Alison. Good to meet you all. I think given the topic of the session is trust and transparency in data, we did think collectively, how could we not start without a few declaration of interest? I suppose the only one I have that comes to the forefront is about 2 years ago, I was the lay representative on a program group trying to knit together health and social care data in East London called the Discovery Programme. So that's mine. Would anyone else from the panel, you gave quite comprehensive intros, but if there are any other interests to declare, just let me know. If not, good. Let's go straight into the discussion then. And Caroline, I thought I might come to you first on this topic because we wanted to start off the discussion by just situating ourselves in what the current context is, because I think if we were holding this event right after care.data had done what it eventually did, or at the height of the Cambridge Analytica issues, the debate around trust and transparency would have been in quite a particular place. So could you just sketch out your perspective on where we are on the issue of trust and transparency and how data is used to improve the health and well-being of the population? Where are we at the moment?
So I think through the pandemic over the last year has moved the conversation on quite a bit. So we have actually, particularly in the cases of actually having some very, very concrete examples of the benefits of using health data to kind of improve our lives, to help us understand where we are with the pandemic, who's got the disease, who's being affected by it, who's getting indirect effects associated with it. So as Debbie was mentioning earlier, the impacts on cancer patients in terms of their treatments on that. So the how it's being used through clinical trials in terms of identifying recruitment for clinical trials or the outcomes affecting people. So data has been an incredible tool for us throughout the whole of this last year. and been very much, in addition to that, it's been very much in the public eye. So people are seeing this information and data on a daily basis and are becoming actually really knowledgeable and expert in how data is being used and how we're driving different parts of and seeing the almost the evolving kind of learning and lessons coming out of it, which has then changed the conversation around actually people now understand why data is being used. They can see the value from it. They can see the problems of not having the right data. They can see the aspects of where different groups are not represented effectively in there or getting messages in differently. So I think we've now got a very compelling story as to the power of health data and how it's actually helped us through this period.
Thank you. And I'm glad you mentioned the recovery trial, because my public affairs colleagues talk a lot about cut through. I can't think of anything that's cut through like the recovery trial in terms of people who don't work in the sector coming up and asking questions, really informed questions about it that I clearly can't answer. So I think that's a wonderful example of the benefits of health data. But Jennifer, this reminds me of a conversation we were having over the recovery trial. It's done in the context of such extraordinary circumstances where you're trying to prevent immediate loss of life. And I think you had a perspective on how some of the things that the health service might be doing in the longer term might be happening in different contexts to the operational one we're in the moment. So what's your perspective on this?
Well, actually, I guess that would probably be in relation to a witness seminar that I had the fortuitous opportunity to participate in through the University of British Columbia. And I think it's just giving consideration to the fact that right now we are in a different time of extraordinary circumstances in which we have to give different considerations to how data is accessed and shared for the purposes of our response, but then also what that needs to return to when we come on the other side of a pandemic, and how we can establish policy going forward to ensure that we're better prepared next time. So things like sunset clauses, and if we're going to enable extraordinary access to that data for the purposes of the response effort, we need to make sure that our patients and individual citizens are protected on the other side of that data is used in a responsible way, and that when it's no longer needed, it is deleted beyond the purposes of any beneficial research that could be used. And even then, that's more around making sure that we're deploying the proper privacy methodologies so that re-identification of data, individual patients within those data, cannot actually occur, so that we can benefit as a society, but then individuals are also protected. So bringing balance to that.
Great, thank you. And did you have any wider comments you wanted to make around how the environment has changed or the climate's changed?
Well, I think to Caroline's point, there's definitely a burning platform that has been set through COVID, the value of data sharing and how it can help us as a society and how we need to come together in the context of data to respond to these things and progress innovation and science. But I do think that we still have some opportunities for improvement in how we actually do this. And one of those is, some basic elements of modernizing our policy. A lot of our privacy regulation, with the exception of GDPR, was written in a time where we didn't have iPhones. So we're not considering the acceleration of data collection and access to multiple parties, and that understanding of how the data is being used is not fully there. So, really recognizing that privacy and protection is two elements. Privacy is around the individual's right to exercise autonomy over their data. Understand, as Caroline said, where it's being used, who has access to it, for what purposes. And then if there's things like GDPR that apply, what their rights under those local privacy laws are. But then also protection is around making sure that the data is actually protected when it's exchanged. And that there's two elements there that we have to balance. And it's not just about either hoarding the data or fearing the data. It's about finding a way between those two so that we can derive benefit for value or for society overall.
Great, thank you. I think this was already helping clarify things in my head, at least, that we won't assume that things will just bounce back to how they were before the pandemic. But at the same time, the way we're operating now is not it. This is not necessarily the future. But perhaps the climate and the way we're thinking about and talking about these issues has fundamentally changed for the better. Alistair, could I bring you in, please? Because you wear three hats, at least three hats. So as a data user, as a researcher, someone working with industry partners, where do you think we are now on trust and transparency? And how have you seen that change compared to other, earlier parts of your career, perhaps?
Yeah, thanks. So I was really struck as we were hearing Jennifer talk through that, how quickly things change. And I think one of the things that, again, COVID has taught us is that how rapid the transfer between data to knowledge to practice can be. And this is really key. So I think in the past, we've often talked about data as an entity with vague value back to patients, and everybody could say yes, I see why that could be useful, but we've always thought in sort of 10-year, 20-year time before one would actually see the benefit of that. And I think what we've seen is that even on a weekly basis, we have new insights coming in, it's sometimes even daily, that are coming out of clinical trials, that are coming out of not just the interventional trials like recovery, but a number of other studies, which is simply data gathering. It's simply spotting patterns. It's interrogating what's going on. Why are some parts of the country responding differently to others? And this has been absolutely critical to how we, as the UK, have been able to respond to this. And so I can't think of a better example to us as a nation, and indeed as the world, in terms of the value of health data and how this can positively impact. Now, I completely agree, though, that doesn't mean that there's a carte blanche to kind of just make all data available in a kind of non-safe way. But I think it's really helped move the story on, because now we can see the value. So that's not in question. The question is then, how can we do this safely with due trust and transparency?
Great. Thank you, Alistair. Debbie, can I bring you in for your perspective on where we are with trust and transparency? And obviously answer the question as widely as possible, but I'd be really grateful if you could repeat something which you were talking about earlier, which again really helped crystallize things in my head about patients not being there's no one patient view, and the variety there, which I think was just really fascinating and helpful.
Yeah, I think it's really important to hold that in mind, that there isn't one single patient view or public view on use of data or right to using people's data. And people have the right to privacy if they want to exercise that right. And we do need to hold that in mind. And I think that's one of the issues when we go back to care.data and what happened there. One of the difficulties, I think, was that the people who were most trusted as far as public and patients are concerned were their primary care, their GPs. And a lot of GPs didn't feel that they had sufficient understanding or enough information to help people understand what was happening or what the proposal was. So that absence of understanding really didn't help care.data, and that's one of the things I think we needed to learn from care.data is about making sure that whole system is in place, and to facilitate those conversations between the people closest to the public and to patients, and to nurture those relationships. And that's really how you build the understanding, how you build that underlying trust. So that's one thing I really do want to make sure that we take forward, that there isn't a single view, but we can build trust by helping those relationships.
Great, thank you, Debbie. And I know if you're a particularly seasoned observer of this topic, it might sound really obvious that you can't think about patients as one unified view, but I honestly can't tell you how many conversations I've been in where the patient voice is talked about almost as if there's one patient you have to have a conversation with. And even worse than that, you only need to have the conversation once. Let's talk a little bit about the benefits. Why does this matter? And the question that I keep coming to is, what did data sharing ever do to me? Do for me? How did it help my health and well-being, or the health and well-being of my community? And Jennifer, I think I was interested in your perspectives from stepping back a little bit from the policy question. How good are we at articulating the benefits of data sharing, and how do we make it real? And then after that, Alistair, I wonder if I could come back to you for some of that cycle back into changing practice. But Jennifer, what are your thoughts over the benefits? How would we articulate them?
I think we can do a better job. And I think, to Debbie's point, we need to sort of separate different ways that we're having those discussions. Because I think a patient relative to a general citizen, both have data that is very valuable to progressing science and innovation. But there's going to be a different conversation that happens there in how it actually serves each group and individual. And then, to your point, Debbie, earlier, at the individual level. Then there's also a broader societal benefit, that there's a whole discussion around the data economy that's emerging and all of our roles within that, and that's much broader than even health. And what does health have within that differentiates from other players? And I think right now we're seeing this discussion of trust and transparency largely impacted by actors in those other sectors. And we need to do a better job of differentiating that our objectives is to actually bring together science, molecules, diagnostics, care pathway interventions that all serve patients and help provide better, higher quality care to patients, versus how data and the trust and transparency discussion is largely being driven for other purposes. So I think we could be doing a better job in articulating exactly what our intentions with that data is, how we are using it, and what protections we're, to Alistair's points, that we're actually applying to that data that isn't necessarily being deployed in other contexts. That we have a long history in healthcare due to the regulation and the environment of working with data and in a protected way to make sure that patients' consent is received, and we can do a better job, that the data is being used for the intended purposes and not for any other purposes. We're deploying data minimization principles in that the data that we're collecting is only being used in the way that it's agreed upon when it's provided, and that patients in particular understand that. So I think those are just some high-level comments that probably opened a bigger ball of wax.
Yeah. I liked how you were talking about them. You were talking about the multiple levels there. That yes, there are some wider benefits to society, but the benefits to me as a patient, even if that includes not having to tell my story twice or 7 times or 8 times to different parts of the health and care system. So, Alistair, can you speak a little bit more about these changes into practice? And then, Debbie, I wondered if I could bring you in afterwards.
Yeah, no, thanks. I was really struck by what Jennifer was saying there, and it's a reminder in my daily clinical practice how often I'm frustrated by the lack of data, and what I mean by that is I'm always trying to make the very best decision I can for that patient in front of me, trying to deliver the very best clinical care. And if you think about the process that a doctor's going through or another health professional's going through, we're assimilating data all the time to make a diagnosis, maybe a kind of subtype of diagnosis, maybe to assess severity of condition. And then we're processing that to try and make the best treatment. I was going to say decision, but to give the best information to the patient so that we can share that treatment decision, and shared decision making is an increasing and important theme in the way we deliver healthcare. We may also be discussing preventative measures, might even be discussing whether this is an inherited condition and can it affect other family members. And even just as I dance through that and kind of not touching a load of complexities on the way through, you can see that the more data that health professional and that patient have critically together, the better informed they are to make the best decision possible. Doesn't mean that we'll always get everything right, but we've got the best chance of making that best decision.
I think that's really helpful. So you've taken us into a room where a conversation is happening, and it's about having the most informed conversation possible. And I think what's really helpful is having data flow into a reservoir that you can dip into is incredibly helpful. It's absolutely necessary, but it is not sufficient to have that best conversation. So there's an awful lot of work that needs to go into turning that data into knowledge and then also into practice and having the information there in a helpful form for those conversations. Debbie, what's your perspective on the benefits of data sharing, why it's so important, why it matters?
I think just a laser-like focus on improving outcomes for patients. It needs to be about improving treatments, improving clinical decision-making, shared decision-making. And if you keep focusing on what it brings to people, whether that's at population level or to an individual patient with a specific condition, that's crystal clear. But there's a lot of what Alistair was saying there was making me think, about shared decision making is a brilliant idea, but underpinning that, there needs to be understanding on the part of the patient, of their family, of their carers, so that they can share in that conversation equally. So they need to understand their clinical record, they need to understand the context. And that sort of literacy or comfort around our health data is not that widespread. It's still quite rare. We need to do a much better job on that. And I think there is potential there, but we need to become much more confident and used to talking about that and find space to help people take part in those conversations as equals. And I think that's really one of the areas that we could do much more on. And also going back to direct care, I think a lot of people don't have a brilliant experience of their care records being available to the doctor sitting in front of them or to the nurse sitting in front of them and said, well, where is your x-ray? I can't see it. So when we get better at the system being more seamless and the record systems talking to each other so that we can perceive benefits, and that's, I don't just mean economic benefits, but where patients don't have to struggle to retell their story again and again and say, oh, but this happened, did you not know? I think that gives people much more confidence in the idea that there can be a useful ecosystem for data, because if their own personal experience isn't good, it's really hard to convince people that you can somehow take this data, aggregate it, and make something good from it, because a patient can see the individual gaps.
Great, thank you, Debbie. You've taken me back to that room I was in on the East London data sharing program, because the chair, he would always introduce every meeting, which were really frequent, by saying, so we're here to work on this data sharing program. The reason we're doing it is to prove the outcomes and experience of people in East London. And I used to think, why, it's the same cast and we meet pretty frequently. Why do you start every meeting like this? Until I realized that was why. Before we get into all the technical detail, you need to be absolutely have your Northern Star of why you're doing it. Caroline, can I ask for your take from, again, a very different perspective on the benefits, why it matters to have good data sharing?
So I think, thanks. I think others have set out beautifully as to why it matters so much in a range of different areas. I think I'll give one very specific example, which for me shows, and I think there are shows the kind of breadth of ways in which health data can help us, and very practical ways. So if I take the Principle trial, which is a trial used during COVID for therapeutics or treatments for people with COVID in the community setting. So recovery is about the acute setting, Principle's about in the community setting. You think to identify people who've just got COVID, who are suitable for entering that trial across the whole of the country is incredibly difficult to do unless you have data. So if you're trying to just phone up GPs and find out who's got that, by the time you've done that, you've kind of missed out on or hoping that someone finds a website and volunteers to do it. So, and by being able to bring in data, we're able to find that by using the data around test and trace information, you're able to find people who've got COVID within 24 hours, contact them to say, would they be interested in participating in a trial? By doing this, we're able to see a 4- or 5-fold increase in the number of recruits to a trial. Now, the reason that matters is as soon as you go from, say, 800 people or so in a trial to 4,000 people in a trial, you can do many more contestings of evaluating different types of treatments. So this changes people's lives. If you're evaluating more treatments, you stand a greater chance of being able to find something that works. Currently, we do not have anything that works in the community for if you have COVID. There are no treatments at the moment that have been tested for that. So these are really practical things that data is saving lives by being able to do this. If we can get more people involved in this, so just there are very, very practical ways which sound really obvious, but they just haven't been happening. So I think there's a lot of the case people aren't realizing quite how little the data is being used for things that sound blatantly obvious. Of course you'd want to do that. So I think in many cases, almost we're just scratching the surface of what could be done with data.
Great, thank you, Caroline. And I think these have all been great examples of the multiple levels at which you need to be crystal clear on what the benefits are of data sharing, because there are multiple benefits, but are we being clear enough? Are we having the right conversation in the right way? I think that's one of the themes that's really come through. So let's move on to some of the challenges then, and potential pitfalls around data sharing that we've run into in the past, but particularly focused on the present. And Alistair, I wondered if I could come to you first, because you spoke quite passionately the first time we met about some of the people who might be left behind, but also in how some of the health inequalities and inequalities we see at the moment might be amplified by greater use of data sharing or greater use of technology.
Yeah, no, this is something that I think is a significant risk. And it's not so much about a risk around data sharing as such, but is around sort of selective data sharing. And what I mean by that is that if we derive all our knowledge based on clinical trials, we are sampling that small proportion of the population who are happy to be enlisted in the clinical trial. Maybe they can more easily engage for whatever reason. They are more trusting of health systems, and what we find when we've looked at the kind of demographics of people who engage in trials or enlist in studies such as the UK Biobank project is it's not really representative of the whole population. It tells us an awful lot. There's a lot of knowledge that comes from these studies, and it's really important, but actually it's not complete. Now, this has probably always been an issue, but the reason why I'm particularly concerned about it now is that we have data-driven technologies coming in. So systems like artificial intelligence systems, AI systems, which are using that data to make sort of decision recommendations, which can influence treatment, prioritization, triage, and so on. Now, I think that's a really powerful and helpful technology. But imagine a situation where these technologies are only trained on a certain cohort of society, or maybe on the majority of society, but leave out major groups within society, and which are likely to be those that are seldom heard. They're maybe from communities that don't engage so well with health services. So this is a long way of saying, Shiva, that my concern is around not so much those who do share data, but those who don't, that there's a risk that they may be left behind. And this perhaps comes back to one of Debbie's points earlier. We were talking about consenting for the use of data in the research context. But there is value also in what we call routinely collected data. So I sometimes talk about the everyday encounters, which I touched on earlier. All that knowledge that is trapped, but it's not used because it's not in the midst of a clinical trial. And so I think there is an important conversation about how, in a safe way, in a way that the data is always anonymized and that people can opt out from, that we use that routinely collected data, particularly when it comes to these data-driven technologies, to ensure that a retinal diagnostic system to detect macular degeneration before somebody loses their sight works across the whole population. Some other AI technologies that I know well and are in deployment, things like spotting skin cancer diagnosis, again, that they work for everybody. So that was the specific concern. So we call that health data poverty, where sections of society maybe are missing out because actually we don't have the data to inform the sort of treatment decisions and the technologies around them.
Great, thank you, Alistair. I think it comes back, doesn't it, to this best possible conversation. And if it was you and I having a conversation about my health on a system that had been trained on people very different to me, it's hard to have that best possible conversation. Sticking with pitfalls then, Caroline and then Debbie, I wondered if I might ask for your perspective. What do you see as some of the big pitfalls that we should be aware of if we really do want to support this data sharing agenda to improve health and well-being?
So I think I'll take a slightly different tack from Alistair. Completely, very much agree with Alistair's points on there, but adding kind of another angle into the mix, which is if you think there's just a vast amount of data that's out there. So we have, first of all, I think one of the big challenges is, do we know what data we're actually talking about and where it is? We're starting to tackle some of these kind of aspects. So, for example, we have the Health Data Research Gateway, which effectively enables you to discover, there's over 560 of the data sets discoverable on there. But that's across 40 or so different custodians. So the data is very fragmented out there. So actually, how do you actually draw on it, find it, use it? And then you get into where the data is actually securely stored. So if you want to be able to access it, and there's been great advances on trusted research environments, streamlined access processes. So all sorts of things to actually make it possible to use the data, I think, is a really important part of solving the problem in a trustworthy way. You then get into, well, given there's vast amounts of data, are we asking the right questions of the data? So one of the things, if you've got, you can get yourself boil the ocean in all of that data and actually come up with nothing terribly insightful. But really, are you asking the right questions of it? Are we then actually drawing out the sorts of things that Alistair was setting out in there of going, well, actually, are we asking the questions that are drawing out and making clear that we've got these gaps in data sets and things in there? And I think there's just this huge amount of almost that whole flow through of that lovely kind of process Alistair was setting out, which is really getting us to insight and results that actually needs to be systematically worked through and systematically addressing each step of that journey. So we're gradually learning how, as a society, to use data better and better and better.
Great, thank you. Debbie, what was your perspective?
I think for me, one of the biggest issues is really making sure that the people, just general people, are properly involved all the way through. So a group of researchers can decide that they think something's terribly important and we're going to spend time and money looking into that. But we actually need to make sure that the public, that patients agree that this is responsible use of this data, that this is worthwhile use of this data. This is, in fact, the most burning question. And if that full circle of people agree, that makes sense. But if it becomes a selective, closed discussion between researchers about what's important and what's not, and if citizens aren't involved in that, then I think that's a real problem. And I think that's where the disconnect can come, where people don't agree that this is what's important. And then if they don't agree, why can they, how do they say, okay, carry on, do that with my data?
And I think that phrase you used of the whole way through is just so important. That engagement is not a one-off. It is a continual process. I am keen to get to the Slido questions, given you took the time to provide them. And we had three that I'd like to cover. And the first one was around, well, let me read it out. So how do we persuade clinicians to ask patients for consent to share data? Clinicians don't necessarily have the time and are unsure how to talk to patients about consent. So I wondered if we could get Debbie and then Alistair's perspective on this question about how clinicians feeling empowered to talk to patients about consent for data sharing.
Yeah, I saw that question earlier, and I was a bit taken aback by it, I think, initially, because clinicians talk to patients about consent for so many other things. So why is data different? And I'm still trying to get my head around this, but I think it's because clinicians are not yet used to doing this, and it's not part of everyday practice. And I don't know the how this comes about, that it's different. Why informed consent for data sharing is different for informed consent for treatment or for whatever. But I think it's something we need to get better at. I'm still not quite sure what the right answer is.
Great. Alistair.
Yeah, I think this is a difficult one to answer succinctly, because it speaks to that kind of the whole of that relationship, how we as a health professional interact with the patient, and what is it that we assume and what is it that we explicitly ask. And if you think about the whole consultation, there's a lot that is just assumed that, I'm assuming that I'm given permission to ask really personal questions that I wouldn't dream of asking you at the bus stop. And yet we don't sort of formally go through kind of, ask for consent to do that. So, and I think it partly speaks to the fact that we haven't really thought of data as a thing that has any importance beyond that initial consultation. And I think that, to Debbie's point, as we understand that actually the insights that a patient gives in that consultation are incredibly valuable, both for delivering care to them, but potentially for many others, because it enables us to join dots and understand. Then I think that both patient and health professional will understand the value of that, and that's probably will become a better and more informed conversation going forwards.
Great, thank you both. And linking back to Debbie's earlier comments about the timeline, I think it also partly goes back to, if you feel confident in the narrative over this is why I'm asking for the consent, if you have confidence, that makes the conversation easier, I believe. So let's move on to oh, sorry, Debbie, go ahead. Yeah, do come in.
Yeah, just one quick thing on that is really what the missing link in this is that patients don't routinely have access to their own data. So they don't know what's in it. But it's quite a big ask then to ask patients to give consent for their data to go somewhere else if they don't know what is held in there. So I think that's something that we need to address too.
Yeah, absolutely spot on. Jennifer, you wanted to come in as well.
Something that we've lived and experienced in the context of informed consent is actually identifying the differentiation between primary and secondary use. So primary being for the purposes of delivery of care, so consenting to that. And then for the secondary use, I think to Debbie's point, it's making sure that the clinician is supported in that they understand the data management and they can articulate those things to the patient, and then vice versa, that patients feel comfortable and have understanding to ask those questions as well. So I think it's a two-way street that we can do a better job on together.
Great, thank you. Caroline, did you have a perspective on this?
I guess just picking up on Jennifer's last point and things on there, I think something, I guess, through the COVID period has been the collapsing together of primary and secondary uses, in terms of actually we've seen that time turning around so much faster, of rather than seeing something goes off into research and disappears for a couple of decades, we're actually seeing things coming back within days, weeks, months. So I think that blurring together of what is primary versus secondary is a really important space that we'll start getting into.
Fantastic. Thank you all. Let's move on. And what I might do is combine these next two questions, because they were broadly around communicating with the public about the benefits of sharing data. And there was one question which was, what could we learn about from 2020 about communicating better with the general public on the purpose and benefits of safely sharing data for care planning or research, from Ben. So what have we learned from 2020? But then there was also a question from Laura over what's the best way of providing this information to patients about their data and how it's used. And she brings up the example of paper leaflets being sent to you to talk about the benefits of digital sharing of your data or a letter. So could we hold those two things together? What have we learned from 2020? And also, what's the best mechanism for having this, or mode for having this, or way of having this conversation with the general public? Who would like to come in first on that one?
I'm happy to jump in on that one. First of all, I think it's actually coming back to the point that everyone's raised through this is the integrating patients and public into the whole process throughout. So if by bringing patients and public into the very specific examples that are being worked through. So we've had patients and public, and Debbie's been very kindly volunteered lots of time doing this, of actually prioritizing the research questions of all these possible things we can do. Which ones are these most important to people? Which ones are most valued? Then as the questions are being fleshed out, as the work's happening, having patients and public involved in the design and the approach that comes out to understand what are the perceptions, what are the worries about this, how might people receive this? You then end up with very tangible examples of where patient and public are able to shape and design things in a way that become very practical applications that people then find acceptable. And you have also great case studies that you can then communicate back to the members of patient and public to say, this is the value of how data is being used, and this is how people have been involved in creating it. It is yours, and it's for you, and it's for all of us. And I think rather than it can be a little bit communicate something over here, engage over here, whereas actually it's a whole journey that we're all producing. We're all parts of this kind of threads of a rope producing these outputs together. It's not just one part here and one part there. And the more we can bring this together, the more we'll have compelling stories that everyone feels, oh yeah, I recognize I was part of that. I contributed to that. And I think that makes it much more exciting for all of us.
That's great. Thank you, Caroline. When you said threads of a rope, I thought of the comments you'd been making, Jennifer, earlier when we were meeting and talking about how you can't see trust in transparency and communication with the public as this work stream over there, work stream 17 of a program on improving health and well-being. What was your perspective on communicating with the public?
Well, and I think it's even to Caroline's comment to one of the previous questions, there's a lot of work to be done around just the basic data infrastructure and ecosystem that will generate that trust. And so I think then the next piece and what we've learned from 2020 is we can do better next time. We can have policies in place and lessons learned from the data collection elements so we can be faster to respond than we were even this time, which was accelerated, as Alistair pointed out. But I think we need to follow some of the where informed consent is moving as well, in that we're deploying more plain language in the modality that the patient group is comfortable with, or the individual patient, because it is going to be variable. There are going to be individuals that are going to be much more comfortable with a paper leaflet relative to someone who is going to want to engage with an app that they can then navigate and dig further. So it's going to be a spectrum, and we need to be prepared to respond to that in a way that is digestible. And you could consider as a data subject, and we're all on this call, data subjects, we feel comfortable that we understand how that data is going to be used in whatever context, whether it be pandemic or not. So I think that's something really important going forward that we can all work on.
Great. Thank you, Jennifer. Debbie, do you want to come in, and then Alistair, I'll give you the final word.
Yeah, I think for me, really, the communication is key, and it depends on the context. If you ask people how they want you to communicate with them, they'll tell you. It's not that hard, but it's not for any group of people on any call to say how best to communicate with a specific group of patients or a specific section of the public, or the public in general. But I think the more channels, the better. It shouldn't be digital by default, because that just excludes so many people for so many reasons. We need everything. We need to be able to just sit and talk about it. We are we're social beings. We're not, I know we're data subjects, but we are human beings at the end of the day, and we need to be able to talk to each other about how we feel about these things. And I think it's really important not to overlook the importance of those face-to-face relationships, given that they're kind of hard to do at the minute, but they really are how we understand each other.
Great, thank you. And Alistair? So, Shiva, I don't think I should have the final word. I think my role is to listen, and so I think we should leave the final word with Debbie.
Quite so. So what is the best way of providing information to patients about their data and how it's used? The message I've received is, yes, we should absolutely learn and provide a full menu of what works from previous experience. But if you haven't spoken to them, how do you know? How do you know how people want to receive the information? And also something about creating a space that, again, this isn't a bang. We've had the conversation. You've had the leaflet. You now know exactly what is going to happen. It is an ongoing dialogue in a space where you feel comfortable having that dialogue and the confidence to have it. So thank you all. And I'm glad we managed to get some of the Slido questions in. I did say that I wanted to have this sense of agency, that people don't leave thinking, wow, there are a lot of big topics here. I hope that some national regulator comes up with some really good guidance that will answer all of these issues. So back to this sense of agency, based on your experience and your expertise, what can help? What can help if the exam question is building better trust and transparency in how data are used? So I wonder if, again, I could start with you, Caroline, and then perhaps come to you, Debbie, and then you, Jennifer, and Alistair, on this question of what would help? What have you seen make a difference?
So I think, what would help is involving everyone throughout the process and realizing it's our job to do that. I think what would help is to take the example of what's happened within COVID and realize quite how extraordinary the developments and benefits have been in that. And what if we could do that in other fields as well, in other areas? So Alistair's touched on eye disease, Debbie on cancer, there's Alzheimer's. If we can use and deploy this sort of scale of improvement that we've achieved in COVID through using data, just imagine what we could do in other incredibly important areas as well on that. So I think it's that sense of retaining that sense of urgency and importance over this. This is not something that just happened and then let's put it in a box and wasn't that an interesting experience and move on. This is something actually, how can we lock in these benefits and improvements in a really trustworthy way, which involves all of us working together going forward on it. So I think it's using this point in time we have now to actually build these behaviours going forward. There are then all sorts of aspects, as Jennifer's mentioning, in terms of the kind of the infrastructure, the pieces of the puzzle we put in place to make that really work, and having everybody involved in those and starting to understand them. They can come across as quite complex initially, as you but actually getting our heads around, getting the language simple, and so people can really, all of us can understand, well, actually, what does that mean and what's the implications of that, rather than it being perhaps a bit opaque as to what's going on behind the scenes and aspects. But these are really important parts of our healthcare system. It's not something on the side. This is the future of healthcare is going to be in this space. So we really need to, just as we understand a hospital or a primary care, we need to understand how data, the infrastructure works, and how it's been used for our benefits and where the limits of it are. So I think it's all of us, members of the public, recognizing this is an important space for us to really, we've got a taster for it. Now we've got to learn more and keep learning so that we're kind of really playing an important part in it going forward.
Thank you. Debbie, over to you.
I think really for me, it's about transparency and explicitness and making sure that everything is given a good shake out in the daylight. There's a lot, because things are happening so quickly at the minute, it's very difficult to communicate in a way that's easy to understand what's happening and why it's happening. But that's a really important check, that this is why we need sunset clauses. This is why we need to realize this is not normal. This is not business as usual. So we need some breathing space to understand what we can do going forward. And is everybody okay with what we've done so far or not? And take some time to understand where people don't feel that they can trust the actors involved. Why don't they trust them? and unpick that. Don't just say we don't, we're not trusted. Is there a reason? Is there validity to that? What can be done better to improve that? And I think there's also a feeling that some people are being left behind because digital by default seems to be the way things are heading. And that's really not going to help this particular area of healthcare. It's really going to be a big problem. And we need to think imaginatively and cooperatively to fix that. I don't know that there's not going to be a silver bullet to fix it. There's lots of work that needs to be done there.
Okay. Thank you, Debbie. Jennifer, and then Alistair.
I think some of the comments that have been made, it just occurs to me, I think the burning platform is, how is it that we've, as a society, found a way to ensure that data can be used to sell us the most optimal product that we are most likely to buy at the specific point in time, but we're not doing that for our healthcare and to ensure that all populations have access to healthcare. And this is exactly the space where we could be starting to address a lot of these challenges. So I think to me, part of the ethical conversation is how much data in healthcare we aren't using to serve patients and population health. And that's something we need to progress. And I think something that both public and private institutions, of course, our own organization included, we need to be better about communicating our data management practices, the principles that we're working against. And we need to be investing in a lot of the pieces that Caroline and Alistair and Debbie have all spoken to, in terms of what the infrastructure and policy needs to progress that ecosystem. And then finally, we need to make sure that our actions are really backing that up, and that doesn't matter what's coming out our mouth, all of our actions are demonstrating exactly those tenets and principles so that we can build the trust. Because I think one of the challenging things with trust and transparency is that, it can take forever to build up and seconds to break. So we need to be cognizant of that and ensure that we're all engaging as responsible data citizens.
Thank you, Jennifer. Alistair.
So I would just echo the comments of the rest of the panel, but one specific concern I have is around people being left behind. So this comes back to the comments I made earlier about the potential for health data poverty, and the fact that we need to make sure that we're in a safe way that is that we, as the wider public and patients, are supportive of, can make sure that there is appropriate data available so that we understand the needs that are faced by the whole population, that there aren't people left out. And particularly as more and more data-driven technologies such as AI come on board. But that needs to be part of a conversation. That's something that we work towards together.
Thank you, Alistair. Thank you all. So I think what you've just talked about, the need for a constant dialogue with the public and patients, the need to articulate at multiple levels the benefits of data sharing and being crystal clear and transparent in the way data are being used. All of that seems to me to encapsulate a lot of the discussion we've been having. And I was trying to think about how to close this, and two images kept coming into my mind. One was being at one of those really fancy restaurants where you get a tasting menu, because every time somebody would speak, I would think that's incredibly, data, health inequalities and data poverty. Let's talk about that for an hour, or let's talk about the recovery trial and how that might have changed the relationship of the public to data use for an hour. So I think what the panel has given you is incredible food for thought, all these little nuggets that you can go away and think about, but also some guiding stars of the principles we need to follow. And the second image was a room where a conversation is happening between two people or more people in a caregiving setting, where that conversation does need to be underpinned by the best possible information, where you don't need to keep telling your story over and over again to get into that room, that everyone has a shared understanding, and that you as a patient or a member of the public has as much right to access that information as possible, so it feels like a genuinely level conversation in terms of power and information and knowledge. I think that's some of the undercurrent of what we've talked about. And while things have absolutely changed because of the pandemic and how data is used, I think the phrase that really spoke to me was something Debbie said about breathing room. We do need a little bit of breathing room to think about how many of those changes we want to carry forward, how many of those changes need to be reassessed. So it's not necessarily going to be this massive jump in how data sharing is used, but hopefully we will see some of the progress that has been talked about for a long time, but perhaps hasn't materialized as fast as we would have hoped. So all that leaves me to do is to say thank you to Roche for their support of this event, and also thank you to the panel for somehow packing about 5 hours of content and thought and knowledge and expertise and experience and wisdom into a much shorter period of time. So thank you all, and goodbye.